Assalamu alaikum wa rahmatullah. So for this lecture, we will move into the lower limb, and we will start with the lower limb with the pelvis and the acetabulum. A very important, nice lecture. It's going to be hopefully fast. So for the injuries to the pelvis, it's less than 5%. About 2/3 of all pelvic fractures occurs in the road traffic accidents. So they are potentially high energy trauma, and usually the patient has other trauma and other deformities, other injuries. So you have to start with the patient, as always I told you, on the ATLS protocol, A, B, C, D, and E. The mortality rate can raise up to 10%. So the surgical anatomy. For the surgical anatomy, let's go to the picture. As you can see here, you can see that this is the pelvis from the anteriorly. We will start with the pubic symphysis, and posteriorly on the sacroiliac joint. So we have the right hemipelvis and the left hemipelvis. And here with me, there will be a pelvis with me to help me in discussion to discuss the pelvis anatomy with you. So here in the middle, we have the pubic symphysis, we have the right and the left hemipelvis. Okay, we have the superior and inferior pubic rami. Okay, we have here the acetabulum. Okay, and we have here the ilium, the iliac wing. We have some tuberosity which are important: the anterior superior iliac spine, the anterior inferior iliac spine. We have the inferior posterior inferior iliac spine. We have the greater sciatic notch, and I'm gonna show it to you. And here you can see this is also the sacrum, okay? And here the lower spine and the coccyx. So basic anatomy of the pelvis. We have here the greater sciatic notch, and we have here the lesser sciatic notch. The pelvis anatomy, actually, it's a bit complex, and there is a lot of important ligaments, vein, arteries, and vital structures. So it's a bit complicated, but this is an overview for the bony part. The pelvis, as you can see, if you look from the lateral view, you can see that here is the acetabulum. We have three colors. Three colors means three bones. So this is the ilium, this is the pubis, and this is the ischium. Anteriorly pubis, posteriorly ischium. Three of these bones, they meet inside the acetabulum, as you can see here, in something in the pediatric age group. It's called triradiate cartilage. You can see it here in this picture. You can see, because it looks like Mercedes-Benz sign, it's the same. So it's triradiate cartilage, because the pubis, ilium, and ischium meet in the acetabulum in the triradiate cartilage. Okay. As I told you, a lot of important ligaments. Many ligaments are in the pelvis, because the stability of the pelvis, the biomechanics, is not very well understood. It's very complex. So function, what's the function of the pelvis? Well, the ilium functions usually weight station in transfer force from the axial skeleton to the lower extremity. So the main function of the pelvis is to hold the weight of your body, of your torso, and transmit it to the lower limb. Okay, the structural equality of bone of the ilium reflects this concept of force transfer, as the bone is the strongest and the thickest in one column that runs from the ischial tuberosities. So when the human being is sitting or standing, or stands face or sitting, there is a difference with the biomechanics. So if you look at the picture, if you are sitting, the weight of your body is going to the sacrum, to the ischium, sorry. So look at the weight distribution. So there is no weight going to the lower limb. But if you're standing, your weight is going to the acetabulum, through the head of femur, to the neck shaft, and the lower limb. So this is the difference between the biomechanics when you're sitting or when you are standing. Some important ligaments. This is the greater sciatic notch. It's like a site where a lot of vital structures are going through. Do you know how many structures we have inside it? About 11 structures. We have 7 nerves, 3 arteries, and 1 muscle, which is the piriformis. We have 7 nerves. One of the most important nerves that's passing from here, the sciatic nerve, superior inferior gluteal nerve. We have a nerve for the obturator muscle, and a lot of structures. So it's very important. And for the arteries, we have the superior gluteal artery, inferior gluteal artery, a lot of important structures, you know. This is a picture showing the normal distribution of your weight when you are standing to both of your hips, but here the patient had spinal fusion. Okay, so you know, or you can see here the disturbance in the biomechanics and the mechanical axis of this patient. For the pelvic stability, as I told you, it's very complex. We have a lot of supporting ligaments. It's very important. You can see here from anterior or posterior, a lot of ligaments like the sacrotuberous ligament in the anterior part, as you can see here. We have the sacroiliac ligaments. We have posteriorly the iliolumbar. So a lot of complex ligaments. The strongest and the most important tethering ligament are the sacroiliac ligament and the iliolumbar, and they are supplemented by the sacrotuberous and the sacrospinous. So if you want to mention the most important ligaments in the pelvis, so you should mention the sacroiliac, iliolumbar, then you should go to the sacrotuberous and sacrospinous ligaments. The primary stabilizing ligament structure of the posterior pelvic ring are the anterior intra-articular and posterior sacroiliac ligaments, sacrotuberous and sacrospinous. So as I said, there is something called pelvic ring. So what's the pelvis ring? If you look at the pelvis anteriorly and you tilt it, this is called inlet view because it's going inside. You can see that there is a circle, this circle. This circle is called the pelvis ring. This is the pelvis ring, okay? As you can see it, this is the pelvis ring. So the pelvis ring is very important, as we will see now in the pelvic trauma. So we keep the ring maintained and stable as much as possible. Anteriorly, we have the symphysis pubis, okay? The pubis symphysis, which is ligaments. It gives very good stability, okay? About 15% of the stability of the pelvis. During bilateral stance, the symphysis and the anterior sacroiliac joint are under tension. So when you are standing on both limbs, you can find that the symphysis pubis and the inferior sacroiliac joint are under tension. But when you are standing on one leg, the symphysis pubis, it is under compression and vertical shear stress. So if you're double stand phase, if you're standing on two limbs, there will be tension on the pubis symphysis. If you're standing only on one limb, there will be tension and vertical shear. So there will be some triangle rotation. Look at this movement. So vertical shear. This is what's happening when you're standing on one limb. Mechanism of injury. Usually, if you want the pelvis to be broken, you have to have high energy trauma, which is mostly motor vehicle crashes or pedestrian RTAs, and so on, and crush injuries. So you have to have high energy trauma. In this trauma, the average for these people is 33 years. The types of injury. So we have many types of injuries. The most important are either isolated fractures with intact pelvis ring. So the pelvis is a ring. Either it breaks from 1 point, 2 points, or multiple, and we will talk about it now. So it's isolated fracture, the ring is stable. Number 2, fractures of the pelvic ring, either 1 point, which is still stable, but if it's in 2 points, it will be unstable. So there is a ring, it should be stable. Fractures of the acetabulum, and the difference between the ring fractures and the acetabulum, that the acetabulum, which is here, as you can see it, this is the acetabulum. What's the important thing in the acetabulum? That it is an intra-articular. So there is a joint in here. So the head of femur is articulating with the acetabulum in a ball and socket joint. So if there is a fracture involving the acetabulum, we are talking about intra-articular fracture. You know the rest. Anatomical reduction, rigid fixation, or absolute stability. Sacrococcygeal fractures. So these are the 4 main types. Isolated pelvic fractures. If you have isolated pelvic fracture, it's either avulsion, and we talked about what's avulsion fracture, that the ligament pulls the muscle. Direct fractures from direct trauma or stress. About avulsion fracture, wherever there is a muscle holding the bone, you can have an avulsion fracture. For example, you have the sartorius muscle is holding in the anterior superior iliac spine. Okay, in here, anterior superior iliac spine. So if you have an avulsion fracture, you will see that this part is avulsed. Anterior inferior iliac spine, okay, which is in here, sorry, this is the anterior superior iliac spine, this is the anterior inferior. The anterior superior, the sartorius. The anterior inferior, you can find here the straight head of the biceps femoris. It's attached in here. So there will be an avulsion fracture. You will see that this piece is out, or anterior superior or anterior inferior. So bone is pulled. The sartorius I told you about, and you can see, as you can see in his picture, in this picture, you can see that there is hematoma. This is the fracture you can see in X-ray, and this is another avulsion fracture. On D, this is a fracture in the iliac blade or iliac wing. So this is the ilium. You can see this is the ilium. If there is a fracture, for example, coming through here, so this is a fracture in the iliac wing or the iliac blade. Direct fractures, like the ischium. So if someone is having a direct trauma in here, he can fracture the ilium from here, okay, the ilium or ischium. So the ischium blade might be fractured from direct trauma. So these patients usually need bed rest. So just stay in bed because it's not displaced. It's not involving the ring. The ring is still stable. It's only painful. Bed rest is gonna be fine. Pubic rami, it's either superior or inferior pubic rami. So this is the obturator foramen. This is the superior pubic rami. This is the inferior pubic rami. Superior pubic rami, inferior pubic rami, and this is the ischium. So the patient can get either superior or inferior pubic rami, especially for the osteoporotic patients. If it's non-displaced fracture, stable ring, same thing. Bed rest, and he's gonna be fine. Okay, let's go to fractures to the pelvic ring. So the ring might break either from one point, okay? Most of the times the pelvis ring, if the trauma continues, there will be breakage on 2 points, okay, which will make your pelvis unstable. So fractures due to direct blow, including fractures to the acetabular floor or ring fracture in pediatric whose symphysis, pubis, and sacroiliac joint are springy. So in pediatrics, because it's cartilage, you know, more elastic, so it's springy. It might rotate and it will not break easily. The second break is not visible either because it reduces immediately or because sacroiliac joint are only partially disrupted. So it's either another point and it's not displayed or the sacroiliac joint is under tension. Okay, so what's stable or unstable pelvis ring? So as I told you, this is the pelvic ring. It should be stable. Okay, stable means that the patient can walk, okay, but there is pain. Unstable, the patient can't walk because his pelvis is unstable. Moving will cause him more pain and so on. Now in the stable pelvic rings, usually the patient is not in shock. Usually, he might be in shock, but usually he's not in shock. The problem with the unstable pelvic ring, so if you have 2 points fracture, for example, pubis symphysis disruption and sacroiliac joint, there will be a fracture, it's named open book. So this is the pelvis ring anteriorly, pubis symphysis posteriorly, sacroiliac joint. So when it's opened, it's called open book fracture. The veins, the venous plexus in the pelvis will be disrupted while it's opening more and more. So the patient can bleed and bleed and bleed inside his pelvis up to whole blood. So the pelvis can accommodate the whole blood. So he's having open book fracture. What to do? By ATLS protocol in the C, because the patient is bleeding too much blood inside his pelvis, you have to close the book. So closing the book with something called pelvic binder. So you should have put pelvis binder. So it closes the book, it will accommodate the blood, tamponade effect, stop of the venous plexus bleeding, saved his life. For the mechanism of injury. So we have these common mechanism of injuries for the pelvis. It's either anterior posterior compression, lateral, vertical shear, or combined. So if you look at this pelvis, the anterior posterior compression anteriorly is pushing and posteriorly. So I'm pushing from the anterior and posterior. This is the first type. The second type is lateral compression, okay? Lateral compression. Third type, vertical shear. One part, one hemipelvis is going up, the other going down, and combination, which is the fourth type. So these are the types. You can see on the left on A, this is AP compression. Usually what's happening in AP compression, the anterior pubic symphysis is disrupted, posteriorly sacroiliac joint, it will open. It will cause open book fracture, more bleeding, bleeding, bleeding. Please close the book if it's unstable. How can we assess this? We do an examination. It's called bimanual examination by pressure, putting pressure by the palms of the hand on the anterior superior iliac spine on the iliac wing. It will be felt that it's unstable, it's opening. Please do this examination once by the most senior, okay? Don't do it every now and then because it will increase the risk of bleeding. In B, here you can see the lateral compression. Usually in the lateral compression, there will be 2 points of breakage in the ring. So you can see here in the pubis, there is a fracture and the ilium. So this is an unstable fracture because we have 2 points of fracture, vertical shear, which is the worst. You can see the right hemipelvis is going up. So the whole hemipelvis is going up. For the anterior posterior, we already talked about the open book fracture that you should save the life. Lateral compression that will break usually on 2 sides, and it will give pelvis instability, vertical shear, usually severe unstable injury, and it may cause retroperitoneal hematoma for this patient, and it might cause him death. That's why you have to keep this in mind, high index of suspicion. For the classification, we have a very nice classification. It's about tile classification. Tile was thinking about the pelvis as a ring, and he wants this ring to be stable. This is the point. So in type A, as you can see that the pelvis ring is stable. Type A1 fracture is not involving the ring, like avulsion fracture, iliac wing, crest, or so whatever. Type 2, A2, which is a stable, minimally displaced fracture. So the ring is still stable, but it's a minimal displaced fracture, but it's stable. If you go to B, we have the instability. It's either vertical or rotational. Type B, the pelvis is rotationally unstable, but vertical is still stable. So B1, open book, as I told you about. Anterior disruption of the pubic symphysis, posterior sacroiliac joint. It's rotationally unstable, but vertically it's stable. Now for the lateral compression, which is type B2, it is an rotationally unstable, and it's broken on 2 points in the ring. Type 3, B3, which is lateral compression with contralateral or bucket handle type of injury. So the more you go with the classification up, the more it's more severe and the prognosis is worse. So we are done with A, pelvic ring is stable. B, pelvic ring rotationally unstable but vertically stable. Type C, rotationally unstable, vertically unstable, which is type C, unilateral from one side, C2, bilateral, C3 associated with acetabular fracture, which is intra-articular injuries. Okay. Now, Young classification, the lateral compression, anterior injury. So he's talking about the rami fracture. So LC1, which is sacral fracture on the side of impact. LC2, crescent fracture on the side of impact. LC3, type 1 or 2 on the side of impact with the contralateral open book injury. So the more you go with the classification, the more you see that the patient is getting worse and worse. For the APC, for the AP compression, which is the symphysis diastasis. What's symphysis diastasis? We can calculate the distance between the two, or the distance for the pubis symphysis. The more the distance, the more the open book is, or the more displacement it is. So APC1, it's minor opening of the symphysis. APC2, opening of the anterior pubis symphysis, and intact sacroiliac ligaments. And the sacroiliac ligaments anteriorly are open. APC3, complete disruption of the sacroiliac joint. So type 1, it's minor, sacroiliac joint is anteriorly. Type 2, the sacroiliac joint opens anteriorly, and type 3 is completely open. The vertical shear, like, is the worst, okay? Displacement of the hemipelvis and the diastasis of the anterior pubis symphysis. Lateral compression. So type 1 of the lateral compression, as you can see, there is 1 point breakage, and anteriorly here the anterior sacroiliac ligaments strain. Type 2, you can see that there's a fracture and complete disruption of the sacroiliac joint. Type 3, you can see a fracture in here. You can see diastasis or disruption completely of the whole sacroiliac ligaments. For the AP compression, type 1 is minimally displaced. Type 2 with the sacroiliac joint. Type 3 is complete disruption. So the more you go with the classification, the worse the patient is. Vertical shear, you can see complete disruption. Here, superior inferior pubic rami, posteriorly sacroiliac joint, and the whole hemipelvis is going up. Clinical assessment, the most important thing, history, physical examination. So you have to go through the ABCDEs, ATLS protocol, save the life of the patient, observe, always observe these patients, admit them, put them in the ICU if they need. Most of the time we need CT scan for pelvis fractures to rule out intra-articular extension, and you could do some chest, abdomen, or pelvis CT scan to rule out any other injuries. In the presentation, you can see that the patient's leg is externally rotated, okay, either on one or both limbs, depending on the injury. And if there is vertical shear, there will be shortening on the limbs. Sometimes you cannot rule out visceral injury, either pelvis injury, internal pelvis injury, or urethral injury. So you should look for perineal ecchymosis, blood at the meatus. Sometimes you have to do PR and look for high riding prostate. But in 2019, in the American College of Surgeons, they omitted the high riding prostate. So we're talking about just blood at the meatus and the perineal ecchymosis with pelvic fracture and hematuria. So these are some signs of urethral injury. And for the internal pelvic injury, you can do a lot of imaging and physical examination. Hemorrhage, as I told you, venous bleeding is the most common. That's why tamponade effects usually work. Arterial bleeding can accommodate or overcome the tamponade effect. That's why sometimes we have to go for angiography. Okay, that's why sometimes you have to consider consulting a vascular surgeon. Sometimes we go for laparotomies and just to do packing, which is damage control surgery. Pelvic fractures, what to examine? Everything. You have to examine everything. So you have to examine for neurological deficit, for lumbosacral plexus, pelvic flange and perineal contusions, ecchymosis or abrasions, blood at the meatus, around the rectum, open wound in the groin or the buttock or the perineum, LLD, which is leg length discrepancy, external rotation of the extremity, any deformity, abnormal pelvic motion. You have to check for the pulse. You have to check for the blood pressure, if there's any sign of the shock. So a lot of things you have to do. Go through the ABCs, which will make your life easy. Then go specifically look, feel, move with special tests for the pelvis and the lower limbs. For the X-ray, we have a lot of views because the pelvis is a 3D object, and when you want to get an X-ray, you will see it as 2D object. So this view is called AP. If you tilt it a little bit, it will be called inlet view. And if you tilt it like this, it will be outlet view, which is Judate views. And if you tilt it like this, you can see the obturator foramen, which is obturator view. And if you tilt it like this, you will see the iliac wing in here, which is called iliac view. So we have a lot of views, usually we do, to make sure that there is no fracture going through the acetabulum. And if you are in doubt, usually you can get a CT scan, which makes your life easy, and you can do 3D reconstruction to diagnose the fractures easily. Well, how to manage these fractures? The most important thing, save the life. Save the life. How to save the life? Stop the bleeding. How to stop the bleeding? If it's open book fracture, close the book. If it's arterial, call the vascular surgeon. You might do angiography. If the patient is unstable, you can open him up and do pelvic packing. Manage of urethral injury. Very important. This, as you can see in this picture, this is tourniquet that's put in on the lower limb. It's like a trousers, and it's being inflated, and it stops the bleeding in the pelvis and in the lower limb. You can't use it for much time, but it's a life-saving measure. This is the pelvic binder I told you about that you put for an open book fracture. And finally, for the treatment of the fractures, more than 60% needs no fixation, because usually it's extra-articular fracture non-displaced. When do you need fixation? When it's intra-articular. So when it's intra-articular, anatomical reduction and absolute stability. So the life-threatening complication, for sure. Isolated fracture and minimally displaced. If there is no life-threatening, you can go for definitive treatment. For isolated fractures, open book fracture, APC type 3, or vertical shear, open book fractures. This is a picture for an external fixator. So they did closing of the book, and then they fix it with an external fixator, as you can see in this picture. And you can see this scar, which is an indication of laparotomy. So this patient was really in a high energy trauma, and he was unstable. They had to open him up, and maybe they did packing. Then they put the external fixator. This is another big picture showing something called a C-clamp. So this clamp brings the two hemipelvises together. It's closing the bleeding. This is an X-ray before the C-clamp. After applying the external fixator or C-clamp, look at the pubis symphysis. It's not disrupted. Look how you hear the diastasis, how much the space is very wide. And they fix it with either external fixator or they put a plate, a reconstruction plate here for the pelvic fracture. Open book fracture, if it's less than 2 centimeters, bed rest and posterior sling, you can put pelvic binder, it will close the book. Sometimes you can use external fixator if your patient is unstable. And if it's more, sometimes he needs surgery or external fixator. Iliac blade usually with bed rest, okay, unless it's going into the joint. The anterior-posterior type 3, the anterior-posterior compression type 3, or vertical shear are one of the most dangerous. A lot of soft tissue injury. The viscera are really in a bad shape. That's why the patient usually have bad prognosis. So they might put an external fixator, or they might plate the patient, or they might do bridging like damage control orthopedics. They might start with external fixator until the patient gets stabilized after 1 week, 7 days, then they go and do the definitive surgery. This is an X-ray for a patient who had like fracture in the superior inferior pubic rami and here on the iliac blade. This is a lateral compression, you can see it. And on the picture here, you can see that the patient was put an external fixator. Look at the fracture, it was very nicely reduced. Complication, DVTs, thromboembolism, very common with pelvis fractures. Keep in mind to give your patient anticoagulants, please. Sciatic nerve injury is very common. You can test the patient after he's conscious for the sciatic nerve injury or neuropraxia. Urogenital problems like urethral injury or persistent sacroiliac pain. So fractures of the acetabulum, because the acetabulum is unique that it's intra-articular. All of these fractures, they were extra-articular. So bed rest, some displacement is okay, but here in the acetabulum, it's intra-articular, we have to get anatomical reduction. It's very important to know the anatomy of the acetabulum, that if you look from the lateral side, you can see here this part, it's called the acetabular roof. What's the importance of the acetabular roof? It is the weight-bearing area of the acetabulum. So if I'm showing you now the pelvis and the femur, this is the femur, head the femur going in the pelvis. So when you push or when your weight is going down to the floor will push you upward. So the femoral head will hit the acetabulum in the superior part. So the superior part of the roof, or the roof, acetabular roof, it is the weight-bearing area of the acetabulum. That's why it's very important to maintain it in reduction, to keep it anatomically reduced and rigid fixation to prevent secondary osteoarthritis that might happen to the patient. This is the, for sure, as you all know, the anterior and posterior part. This is the posterior wall, this is the anterior wall. So acetabular roof, anterior wall, posterior wall, anterior wall, posterior wall, acetabular roof. And 3 bones are getting together in the acetabulum inside the triradiate cartilage in pediatrics, then it fuses. We have something here, the anterior wall and the anterior column. So this is the anterior wall of the acetabulum. This is the posterior wall. But if you go up in here, this will be named the anterior column and posteriorly the posterior column. Why we should know this? Because in the classification of the fractures, we will see that there is more like this classification. So the acetabular wall fractures of the anterior and posterior part of the acetabular rim affect the depth of the socket. That's why it will affect the movement of the head of femur, which is the ball and socket. So what are the column fractures that I told you about? The anterior column extends from the pubic symphysis through the anterior part of the acetabulum. This is called the anterior column. So along the superior pubic rami across the acetabulum to the anterior part of the ilium, all of this is the anterior column. On X-ray, we have the iliopectineal line. Iliopectineal line. So if you look at the acetabulum here, this is the anterior wall, this is the pubis symphysis. So all of this area is called the anterior wall, anterior column, sorry. For the posterior column, it extends from the ischium through the posterior part of the acetabulum. So what's transverse fracture? Transverse fracture is a fracture that's inside the acetabulum. It gives both anterior and posterior column involvement, separating the iliac portion above from the pubic below. So it's a transverse fracture. It is giving the acetabulum two parts, one above and one below. So this is a picture that shows you many types of fracture. So for example, this is a fracture here is involving the anterior part, okay? Involving the anterior part. If you look at here, in C, for example, in the third one, this is a fracture, transverse fracture, that's involving the anterior and posterior wall, okay? If you go back, you can see this is a T-type fracture, which involving two columns, the two columns, the anterior and posterior, and you have another line, so it's called T fracture. This is a fracture that's involving both columns, the posterior column, the anterior column, and the acetabulum. So it's either anterior wall, posterior wall, T fracture, both column fracture. So it's important to describe the fracture. Usually we use CT scan to make sure of the, to confirm our diagnosis. On X-ray, we can assume the fractures by the iliopectineal and the ilioischial line that I'm gonna show you in a minute. Complex fractures. If you have a comminuted fracture, this is like very bad because the hip is one of the important joints that's having or weight bearing for the human being. That's why if there is a comminuted fracture, the outcome usually will go for osteoarthritis and pain, and it may predispose the patient to go later for arthroplasty in the hip. So as I told you, this is the anterior lip or the anterior wall, okay? This is the iliopectineal line. This is the iliopectineal line. The iliopectineal line, if it's disrupted, it will give you an idea that there is a disruption in the anterior column. Okay, so this is the green one, the iliopectineal line. The red line is called ilio to the ischium, ilioischial line. So ilioischial line and iliopectineal line. And this is the anterior lip of the acetabulum. So ilioischial and iliopectineal line are important to keep in mind. Complex fracture pattern share the following, like the injury is severe, the joint line is disrupted, anatomical reduction and rigid fixation, they need operation for sure, and they end usually with bad outcome because of the osteoarthritis. Imaging, at least 4 X-rays, 4 views, anterior, posterior, you could use internal or external or inlet or outlet view, iliac view, obturator view. It depends on the what do you want to see, and finally CT 3D reconstruction. Treatment, for sure, the first thing, shock, save the life. Then definitive treatment can be delayed up to a week, 10 days until the patient calm down and the inflammatory process going down. So you don't induce SIRS, systemic inflammatory response syndrome. So if you have a trauma patient and you operate to him, the inflammatory response will go very high. You will end up by SIRS, systemic inflammatory response syndrome. Conservative treatment, if the fracture is undisplaced, you put him on traction for 6 to 8 weeks. So the patient is bedridden, more anticoagulants you need, more problems, chest problems, PE, DVT, infections, bed sores, and so on. Keep this in mind. That's why we go for internal fixation, because we need to ambulate our patient fast. What's the operation treatment? When to operate? Unstable hip. Fracture distorting the normal bone and socket, which is an intra-articular fracture. Associated fracture of the femur and retained bone fragments inside the joint. So if you have something inside the joint, a bone fragment, you have to remove it because it will cause osteoarthritis. So we have to get perfect anatomical reduction. You can see that in every lecture, we are repeating the same principles. Anatomical reduction, rigid fixation for intra-articular, extra-articular, functional reduction, and relative stability, which is length, alignment, and rotation. Restore length, alignment, and rotation. Some X-rays showing you fractures here in the acetabulum. It's intra-articular fractures, intra-articular fractures. So these are fractures which need fixation. This is a fracture, which is in the acetabulum. You can see here 3D reconstruction. The posterior wall is involved, seems to be T fracture, comminution posteriorly. You can see reconstruction plates are inserted to restore the acetabular congruity. So for the complication, severe injuries, mainly sciatic in posterior hip fractures or posterior pelvis fracture, AVN might be developed even after months or years. Heterotropic bone formation, which is ossification in the muscles around the bone, you can prevent it sometimes with radiation or with indomethacin. In osteoarthritis, which is secondary to the injury. Injuries to the sacrum and coccyx, blow from behind or fall on a tail, like sitting position. If the fracture is displaced, reduction is worth attempting because it will decrease the pain, it will give better reduction. If it's non-displaced, just rest, and there is a pillow that they sit on just to reduce the pain and decrease the pressure on the fracture. It's very bad, it's very painful. Yeah, so this is a X-ray. You can see here the fracture of the sacrum and the fracture of the coccyx. So I hope it was beneficial. This was the first part of the lower limbs. We will continue in the next lecture in the second part, and we will start with the femoral head fractures, hopefully.